This podcast is intended to provide information for educational purposes only and to serve as a starting point for you to have a conversation with your personal physician. Nothing stated on this podcast should be considered medical advice. Consult with your physician before undertaking or changing any treatment plan.
All right. Well, welcome back. We are here with another episode of the Pound of Cure Weight Loss Podcast. We've been teasing this episode for a while. We've actually waited over a year to make this episode. Dr. Weiner, what is our episode today?
So we're going to review that. You're right. It's 15 months for our year-long review. But we've been talking about our review show that we made, and we made this, back in November of 2023 for 2024 predictions. I love that show. Like, nobody watched it though. That was one of the problems with it. So we'll see what happens with this recap. But, listen, we're not going to let nobody watching something stop us from making another one. So we're going to recap our 10 predictions. So last year, before the 2024 New Year, Zoe and I each made 5 predictions about what we thought was going to happen for weight loss. Turns out I thought we did pretty good.
I would say so.
Yeah.
So let's dig right in.
And then as a bonus, at the end, we're going to give you 5 predictions for 2025. A little bit cheating because we're like 2.5 months in, but, a lot of time left. On our time frame, we'll probably review it in June of 26.
Well, and we know how many things can change in the span of a couple months. So I don't think it's that big of a deal that we're a little late.
I mean, honestly, Zoe, that is so true. And I when I meet with patients, because we just kind of uncovered something that we're working on in our Platinum program, that we already had some really great ways to save money, but I think we have better ways, easier for patients, and even probably a little bit of additional cost savings. And I tell patients, like, this is good, but you got to give us some time. It came out like a week or two ago, and we're trying to catch up. We can't even give you instructions on how to use it because it came out so recently. So there's so much flux and so much change in this space right now, which makes it so exciting, which makes the need for a podcast so substantial. But it can be frustrating sometimes for patients because, like, tell me what to do. We're working on it. But that's something we do in our practice every day, is figure out ways for people to get these meds or surgery at a lower cost so that you can lose a lot of weight, keep it off for the long run, and not go bankrupt doing it. All right. So
and with our new Platinum program, we're now able to, you and me, of course, are able to see people from all over the country, not just in Arizona, which I think is a huge game changer.
Absolutely. Yeah. I'm having a really good time seeing these patients. I mean, they're coming in, they've really thought things through. People people come to you in different stages of the process. Sometimes people come in like, I want to lose weight, don't know what to do. Can we talk nutrition? Can we talk surgery? Can we talk meds? And we can talk all those things. But, that's a very different stage versus someone who's like, okay, I had surgery in 2018 and I regained this and I tried this med and this didn't work and here's my diet and here's my food logs and I think that the next step is this. What do you think about that? And it's just very different conversations. And we're seeing, I think, a mixture of both in the Platinum program, but definitely more people kind of coming in with an understanding of where they're going in this whole process. And just kind of ready to execute that. And I think we've really figured out how to get people on these meds, get them to lose the weight, and not have to completely redo your entire household budget in order to make it work. So let's review our top 10 predictions from 2024. So the first prediction I made was Zepbound is in and Ozempic is out. And I think, first of all, I had the benefit of clinical trials, and the clinical trials where they reviewed Zepbound and Ozempic or Wegovy, it really showed a very substantial difference with a lot more weight loss with Zepbound. And there's no question that's what we're seeing in our practice. I almost never prescribe Wegovy or Ozempic. I don't want to say never, I do. But if a patient has coverage for both, I'm always going to offer Zepbound. And also when it comes to cost savings, we see a lot more opportunities with Zepbound to get the cost savings. Now, interestingly, and we'll probably address this in a future episode, Wegovy just dropped their self-pay price substantially. So it's $650 for Zepbound, and Zepbound was always a little cheaper than Wegovy, but Wegovy just dropped it, I think, to $500 a month, which is substantially cheaper and getting to the price, but still a lot of money.
Right.
And we get people on these meds for much cheaper than that still. So Wegovy, I think, is understanding their place in the market.
Do you think that they were hurting, and so they were like, "Oh, we're losing patients because we're way too high. We're not getting as better results as the Zepbound, so we've got to drop our price to try to get more people in the door."
I mean, when you have more demand than you can meet, you don't drop your price. I mean, Eli Lilly and Novo Nordisk have made it very clear to us that their primary goal is to make a lot of money. So if Novo Nordisk is dropping its price on Wegovy, they didn't do that, out of the goodness of their hearts. I think the pharma companies will never do anything out of kindness.
Yeah.
So,
I was going to say, our main motto is do what's right for the patient. And I think we've seen that the insurance company's motto is do what's right for our pocketbooks.
For our shareholders.
Yeah,
yes.
Right.
Yeah, yep. That's who they answer to. So anyway, so I think we're right on this. The market is certainly leaning towards Zepbound. I have patients, actually just today, I have a patient and people come, she came in and she had all these notes she'd taken and she did some research, which again, I love that. I love when people come in prepared to have a thoughtful conversation, that they've really thought this through. They've done their research. It just makes for such a really powerful, enjoyable partnership in this whole weight loss journey. And on her thing right at the top, I could see her notes is like, want Zepbound, not Ozempic. And so people are seeing this, and at this point, it's really not clear. Now we'll talk about Retrutide a little bit later in the show. That'll be a different story. But anyway, yeah. So Zepbound is in, Ozempic is out. All right, Zoe, what prediction are you reviewing?
Well, I'd say prediction number 1, you nailed it. So prediction number 2, we have plant-based in, keto out. Now, I'm not too sure how I feel about this prediction here, because yes, we definitely are seeing more plant-based, right? We had a vegan bodybuilder on the podcast not too long ago. We see a lot more, shift towards plant-based, absolutely, with more products on the market and that sort of thing. Of course, the metabolic reset diet and what we work on with our patients. However, I do still see a lot of keto-minded weight loss attempts, right? A lot of people still fear carbohydrates to that extreme because of maybe keto trauma and just kind of what they've been ingrained upon with that diet. So even though we're seeing that plant-based kind of come up still, I'm not sure that out is so far out that we can say that it's out. Do you agree?
I totally agree. I mean, I think nutrition can become very ingrained in you. And it's a little bit of a pun, grains and carbs, but it can become very ingrained. And it's hard to change. And once people kind of adopt their philosophy, especially if when they were younger, they lost like 40 pounds on keto, they kind of say, well, okay, that's how it works, because I had that one experience, not understanding that the diet that worked at 25 may not be the diet that worked at 52. And so that change, it's just really hard for people to make those changes. And so I do agree, there's still a strong keto mindset. I think the interesting conversation, and this is something that I think you do really, really well with our patients, and it's a very challenging conflict, really, is when are you pushing and focusing on protein and kind of optimizing your protein intake? And when are you focusing on a produce plant-based diet? And I think, when you're on meds, if you have had surgery, how far out from surgery, how long you've been on the meds, how much weight you're losing. There's so many variables in that question.
Very nuanced, yeah.
Yeah. How do you handle that in your practice when you're working with our patients?
It definitely depends on, like we said, so nuanced, has so many variables,
Yeah.
depends on where they're at in their weight loss journey, if they're in maintenance, right? But something I did want to say about keto as well, and something that I hear a lot of people use, the phrase I hear a lot of people use is, well, what worked for me in the past, right? So like what you mentioned, keto helped them lose 40 pounds however long ago, but the mindset around it is that's what worked. But did it work if you gained the weight back? Right? Did it work if you couldn't sustain that way of eating?
Right.
So I think that definition of it worked. So I'm going to go back to what worked for me before, but like it didn't actually work. So can we do something different?
Right. No, that's a great point. All right. Prediction number 3. It's going to be harder to get GLP-1s through insurance. So
nailed that one.
Well, yes and no. I did and I didn't. So when I made that, we were going right into 2024. And so in 2023, most insurance plans did not require prior auth for the diabetes versions, Mounjaro and Ozempic. And not only that, but they had like $25 copays for these meds because the insurance company said, oh, these meds reduce heart attacks. These are diabetics. They're admitted to the hospital frequently. We don't want to put a large copay in front of the patient because they know copays impact people's utilization of medications and they wanted them to take these meds. And so we were getting everybody. And what that allowed us to do as a practice, and believe me, we weren't the only people doing this. Everybody was doing this, is we just write people a script for Ozempic and they literally would take it and go right down to the pharmacy and fill it and get on Ozempic for $25 a month. And so, yeah, it was really easy in 2023 to get people, and we knew that was going to disappear. It was in the medical policy, so that was kind of a chip shot. Now, if we look at coverage for obesity, coverage for Zepbound or Wegovy, I don't know if I got this one right. I don't know if it got harder. I mean, we see people, I think, I'll tell you what did happen. We saw higher copays. So we had a lot of people getting Zepbound obesity coverage at $100 a month. The copay went up to $200 or $300 a month. This is a question that I'm really interested in working with corporations. If there's anybody listening who's an HR director, we have some creative ways that we're working on to where you could partner with us and we can get you the medications and figure this out at a lower cost. And so I think that's going to be a really interesting field. And I think some creative ways and a lot of the stuff we're doing, it's working in our platinum program for individual patients, but could we take that and apply it to an entire employer group? And I think the answer is yes. That's not something we've done, but I would love to talk to somebody. So if there's anybody who has some influence over that decision and wants to chat, please hit me up. I would love to hear from you. But I think maybe I was a tiny bit right, but for the most part, I think when we're looking at obesity coverage, I don't know that there was a huge change. Maybe a cost increase in the copay, but yeah.
So do you feel as though, because I feel like I heard a lot of people say that their insurance dropped coverage for, maybe they were on a medication and then, in the new year, their insurance dropped the coverage for the medications. Do you not see as much of that?
I think that was the diabetics. I think that was people who we were getting it they never had coverage for obesity. They only had coverage for diabetes, but their diabetes didn't require prior auth. So we never had to submit a form. You could literally, like not every medicine requires a prior auth. If your pediatrician writes your kid for some amoxicillin and they go down to the pharmacy, amoxicillin's like $3. They're not going to do the prior auth. It's just not worth it. It's $3. And so there's a lot of medicines that don't require that. And so that's what I think you were seeing there. But if you're talking about insurance coverage for Zepbound for treatment of obesity, there hasn't been a huge change this year. A little bit, we were a little bit right, but not drastically right. Which is, I think,
Interesting.
probably a good thing. My hope is that it'll get a little, maybe that could be my bonus. It wasn't one of our 5 that we made, but it might get a little easier next year. We might see a little more insurance coverage. Yeah, a little more. I think as much as we saw it worse, it'll be better.
Hopefully next time when we do our 2025 prediction recap, we can give a positive update on that.
Yes. All right. What's the next prediction?
All right. Prediction number 4, AI uses for weight loss. And I feel like we have seen a huge increase in AI, not just for weight loss, not just in what we use it for, but it has truly taken over so many fields and it being useful in so many capacities. But this is something that we are integrating into our new custom app that we are working on. This is the AI use of weight loss. I think we talked about meal planning and, kind of helping with that. And that's exactly what we are working on having our AI, Sage, use it for as well. And what I really like about this is it's trainable and it can be very personalized to, your preferences, your, food intolerances and allergies, and maybe I've seen it where you type in, what you have in the refrigerator and it spits out what meals you can make with it. So I think that in terms of what we saw for 2024 in terms of AI, absolutely has come in with a landslide. And I think we're going to see it increase even further. And I know we're really leveraging it in order to take that care and that personalization and the accountability to that next level.
Yeah. And I think I can just tell you personally, I'd like to hear what your thoughts are on this, but personally, I've always kind of been against that because I've had so many patients over the years have said, just tell me what to eat, Dr. Weiner, and I'll just eat it. And that is, it's great for those first few weeks, but I think I've always been of the mindset of, well, no, you have to learn how to create these meal plans for yourself because I can't be there. You're going to eat for the rest of your life. Me and Zoe can't be there for you for every meal. So this is something you need to learn to do going forward. But now with AI, maybe, can AI write your meal plans for the rest of your life? Yeah, it could, right? It's not that big of a deal.
I'm right there with you, Dr. Weiner. I say the exact same thing. Me giving you a meal plan or Sage giving you a meal plan and you following it perfectly for 2 weeks, if you're doing the metabolic reset diet and you're only eating it, that's not teaching you the skills to be successful on your own. So I do still think that utilizing AI to create these meal plans, maybe you use them longer term, but they're still like integrating these skills and they're maybe without using so much conscious thought around it, they're still getting these skills and learning how to build their meals according to what's aligned with their goals and perhaps the metabolic reset diet. So I do think that it's one of those things where how we previously used meal plans as kind of here's a template, it can be more personalized that you can use more frequently, but you're still going to be learning the skills along the way, which we both are huge fans of.
Yeah. And I think, that just like you said, working with the AI, you're going to learn to meal plan for yourself. And so it's just an extra tool. Another thing I've learned about weight loss, if it's easy, you'll be more likely to do it and stick to it. And so, you know what? Sitting down, mapping your own meal plan every week, that's harder than write me a meal plan for the week, And so I think that's anything that makes it easier. I'm always in favor of that because life is hard. Meal planning is hard. Weight loss is hard. If we can make it easier with meds, surgery, AI meal planning, I'm all for it. So I think that we did nail that one. There's definitely, we're not the only app doing this for sure. Yes. And I think we're going to start seeing this as being a big part of nutrition, and nutritional guidance in the future. So
path of least resistance.
Yep. So lots of people will get Mounjaro from Canada. I I think for 2024, I was wrong on this. But for 2025, I was right. I was just looking a little bit too far ahead. The big reason, in 2024, for a substantial portion of it, we had shortages here in the US. And then we finally got rid of the shortages. When we had shortages here in the US, they had shortages in Canada too. And because Canada is a little bit more of a free market in terms of using market forces to set prices, where in the US we have just crazy PBMs and pharma companies and prices are set arbitrarily. Canada, the prices were pretty high. Now that the shortages are up in the US, and we're starting to see some shortages in Canada, but they're minor and they're getting better. And so just really like right now, we're starting to see the prices come down in Canada to the point where they may start falling to the same level, if not even lower, than what you can get it in the US for. And so I think we really, we had patients getting it, primarily our Medicare patients who couldn't use the coupon. That's who was getting it, but really nobody else. I think in 2025, we may see more people getting it from Canada, even if you're not Medicare. So I think we were half right, half wrong, but big picture, long term, we're going to, Canada is going to be a very valuable part of the supply chain for GLP-1 meds.
Interesting to see what might happen in a year with that.
Yeah, for sure.
All right. So our next prediction, non-diabetes glucose monitoring becoming more popular. So this is one that I think we see a spike of in kind of that influencer space, or the, the wellness influencer, definitely higher end. This is an expensive device, and this is kind of one of those upper echelon kind of affluent. Yeah, it's techie, it's cool. I know we talked last time about it being kind of one of the tech bro type of trends, which I still agree with. There have been very few people that I've come across with in actual practice, actual conversations with real life people who do this. But I do think we see it online in terms of that, increase of getting data. And I'm sure that there's a ton of AI that's in, kind of compatible with that and getting more data from it. However, for the average person trying to lose weight, and there's a huge, what I will say is that there's a big trend of talking about blood sugar stabilizing, blood glucose, stabilization, but through diet, which we work on anyway. So I think it's kind of this, it's staying in that kind of inaccessible, expensive piece of tech that is cool to have or cool to watch your favorite influencer do the experiment with, but not very accessible.
Yeah. Yeah, no, I agree. I think this is a 1% kind of, people in the top 1% kind of trend. Have you ever used it?
Mm-mm.
Me neither. I've never used it.
And honestly, I feel as though that's also a reason why I don't necessarily like tracking my sleep, right? I know there's like an Aura ring that you can use to track your steps and your sleep and all those things. And the data is great. Don't get me wrong. I love data. I love looking at trends. That's why we look at trend for weights rather than getting hung up in the individual fluctuations. That's why having trends of food data and all of these data is great for looking at trend. However, I think when you get too stuck in that nitty gritty daily fluctuation, it can just add more stress, and it can add just another thing to have to track and data to look at that's maybe big picture, not as important or, obviously sustainable long term. And, if we're using it as a tool to build awareness and using that awareness to make meaningful change, great. But if we're getting caught in the weeds and, adding more stress and overwhelm based on yet another piece of data to track, I don't know how valuable it is.
Yeah, I think it's very easy to confuse data with efficacy. So just because we have a bunch of numbers and now we have all this data and here's all the points and here's how much you slept and here's what your blood sugar does when you eat beans versus nuts versus fruit versus carrots versus celery. And so you get all this data and you're like, wow, man, I'm going to figure this all out. But the question is, what are you going to do with that data? And is it actually going to impart a meaningful change in your health? And I think that's where all this stuff breaks down. Is number one, how do you even process all this data? Maybe AI can do it. We'll have to see. But maybe also there's nothing meaningful in it. It's just a bunch of noise. And kind of like the stock market. I mean, we have so much data, an incredible amount of data about stocks and trades and puts and calls and options and, trader volume and all that stuff. And yet none of it allows you to predict the stock market in the future. And so I think we may be kind of in that space with a lot of this biohacking stuff that we see like this, but we'll keep watching it. But yeah, I think it's gotten some traction. I bet the device sales have increased this year. But as far as it being like, oh, this is going to be a big thing, you think it's going to be a big thing in 2025?
I don't know if we're going to see a significant change in one direction or another. I like to think about it as paralysis by overanalysis, right?
Yeah.
Having too much data, you're overwhelmed, and then you don't make any change. So I think, it's more valuable and powerful to make sustainable behavior change, smaller changes that don't require as much overwhelm, because that's more sustainable.
Yeah, absolutely. All right. Number 7, compounded medications on their way out. So I think this was obvious. We knew this was going to happen because it was all based on a shortage, and we knew this med was inexpensive to produce, and that these companies had, billions and billions and billions of reasons why they needed to fix this problem. And so we knew they were going to fix it. Once they fixed it, the law was on their side. They're these huge companies. They're going to win. And that's what happened. And in our episode last week, we announced the dates. But basically, by the second half of April, compounded meds are no more. And, I think I've heard from a number of people in our weight loss space that they were selling compounded meds, and they got cease and desist letters. We never got one. We never sold them. And so that's that. They're over. They're done. Like put the tombstone up for compounded medications. And I had a conversation in a group of people, a group of surgeons. We were talking about it, and I brought up the fact that the shortages are almost over, and this is going to happen, and compounds are going to get shut down. And one of the people said, yeah, but then the next med's going to be up, and it's going to be on shortage, and then they're going to do compounds. I thought that was an interesting conversation to have, because we've got 5, 6 meds in the pipeline. Are they going to be on shortage, and then we're going to see more compounds coming out? I think the drug companies learn their lesson. And when it comes to, once a drug is approved, then it has to then get on the formularies for insurance companies. You can set the price, and you can control that. It's kind of like when Napster came out. It was crazy for all the downloaded music, and everyone was like, Napster, it went crazy. It was the beginning of it. And then over time, now we have Spotify, Apple Music. It becomes very stable and very market driven. And I think we're going to see that. So my hunch is the pharma companies are not interested in letting these compounded pharmacies knock their drugs off. And so I think they're going to control the release. There are alternatives. So if Zepbound's $300 a month and Retatrutide's $900 a month, we're not going to see a shortage of Retatrutide, and we're not going to see the compounders able to move in. So that to me is the bigger question: is what's going to happen with the next batch of drugs? Are they going to be compoundable? I don't think they are. I think compounding is going to be of historical significance only, and I think that's good. It was not necessarily a good thing for this space. Weight loss is complicated. These meds are nuanced. There's a lot on the nutrition side. There's health issues, safety issues. And so we need these to be in the hands of people who are managing them responsibly, sourcing them reliably, so that the dose you're taking is really the dose that you've gotten. And so I think this is a good thing, and it's going to bring a little bit of sanity to this space.
Mm-hmm.
Yeah.
Definitely. Well, guess we'll see. Okay, so number 8, less HIIT, high intensity interval training, more strength training. This is definitely something I would say I've seen. Now, group classes as a whole still are very popular because of a lot of reasons. Obviously that sense of community, the accountability, they like being kind of like why people like meal plans, because you're being told what to do and all you have to do is show up. You don't have to use your brain. You don't have to have that additional decision fatigue around it, right? So in that sense, and a lot of workout classes are more HIIT based. However, with a lot of people that I work with, maybe they still do those group classes, but shifting how they're utilizing it. So, going up in weights and telling the instructor ahead of time, hey, don't get on me for not going as fast because I'm really focusing on my form and slower tempo and increasing my weight. So maybe they're utilizing something like an Orange Theory or an F45, but in a more strength-based progressive overload style, which I think is really great. I think HIIT will always be around because of the essence of it being a short burst, right? You can do, I know we have a couple people who do something like a Tabata in their office at work over lunch because it's the only thing that they have time for, which, 7 minutes of something high intensity is better than no minutes of nothing at all, right?
Actually, pretty good. Makes pretty big difference.
It makes a big difference. Absolutely. So I think it really depends on, again, very nuanced, many factors. But a big piece of it is also goals, like your physique goals, your strength goals. If you're trying to build muscle, HIIT isn't going to be the way to do it. But if you're trying to just increase your movement to help lose weight, then yes, that can definitely have a piece of it. We need to be careful, of course, with injury and injury prevention and lots of those other components, but both are valid with whether you're doing high intensity or strength training, right? Maybe if you're just getting started working with somebody, whether it's a personal trainer or that instructor at your group fitness class, that can really make sure you're doing things safely. So I'm not sure if I nailed this one, less HIIT, more strength training, maybe a little bit, but I think, obviously both have a place, both are going to be around, is my take.
Yeah. I think you nailed the more strength training, but maybe not the less HIIT.
Yeah.
Is there an age where HIIT is not advised? And is that also true for strength training?
So not for strength, even as you get older, it's more advised to make sure you're strength training, right? Not just for the increase of muscle strength, but also bone health, because as you age, you're more more prone to falling, and having those strong bones, the strong muscles, better balance, right? All of those things can really help with that injury prevention. HIIT, I think, is very individual driven. I can't say, oh yes, that's 65, you should stop doing HIIT. But, we see that naturally happen. Maybe instead of doing sprints, you're going for walks. But that lower intensity, LISS is what it's called, low intensity, steady state cardio, as opposed to HIIT, high intensity interval training. I think I read something where the calorie burn, now, of course, the caveat here is we don't want to think about exercise as solely a way to burn calories. But in this research, it was you basically burn the same amount of calories if you're going the same distance. So if you're sprinting for a total of 1 mile, or if you're walking for a total of 1 mile, I can't remember exactly, but I don't know how I feel.
Yeah.
It seems like it wouldn't quite compute. But anyway, what I'm getting at is, I think that taking on an individualized approach, just like with nutrition, but knowing that regardless, having both is important. You need to have resistance training or strength training. You need to have some sort of cardiovascular exercise.
I'm 52 years old. I lift weights a couple times a week. I truly believe in it in terms of keeping you feeling young. And, I think there's more I could do with stretching and that kind of stuff. But I wouldn't set foot in a CrossFit class or an F45 class. I wouldn't last 2 weeks in those classes before something bad would happen to me.
Exactly.
I hear you, but I think with this, the question of how old is too old for strength training, that's an easy question to answer, right? It's like almost there is no limit. For HIIT,
Right.
hold on, not so, like, you got to be a lot more careful. And I think that shows that it might not be for everybody at every age.
Mm-hmm.
Okay, so number 9, bariatric surgery plus GLP-1s is the gold standard for obesity treatment. I think I was partly right, partly wrong. Surgical volumes are definitely down. Our surgical volumes were down about 10 or 15% this year. And I don't know that that's necessarily a bad thing. The way I kind of look at this, and there's kind of this, let's talk about 50 pounds and more to lose. You have less than 50 pounds to lose, it's very obvious bariatric surgery is not the right option. But if you have 50 pounds or more to lose, there are 3 reliable ways that you can lose that weight, keep it off for the rest of your life. The first way is meds with a pretty good response. And it depends on where your starting weight is. And 50 pounds is maybe not the best measurement, maybe 25 or 30% total body weight loss, but a substantial amount. But mostly meds are going to max out around 20-25% total body weight loss, except for about 10 or 15% of people who have that crazy weight loss. And I think we had someone on the podcast last year who lost 100 pounds on 2.5 of Zepbound and basically cut her weight and had 50% total body weight loss on 2.5 of Zepbound. She was a super responder to the med. Her genetics were favorable. And so if you're in that 10 or 15%, you can lose crazy weight, from 350 to 200, like bariatric surgery weight from the meds alone. But 85% of people can't. The next reliable option is a sleeve and the meds combined. You need both. A sleeve alone is not, in my opinion, a reliable long-term weight loss tool. There's some people who will get it, but it's not going to be the majority. The majority of sleeve patients are going to need to add the meds in. And the third option is a gastric bypass. And so I think when we're looking at, 50 plus pounds of weight loss, surgery is still going to play a role, but we're going to be able to select out some people who might have been getting surgery in the past, but now find success with the meds. What do you think, Zoe? You talk to people with meds, surgery, people tend to be pretty happy as long as they're losing weight. That's been my experience.
Yes, absolutely. And I think, in terms of what we see in our practice is that the GLP-1s, if somebody who has a history of bariatric surgery, whether it was a couple months ago or a couple years ago, adding in that GLP-1, if it's for weight regain or if it's help getting them to that total body weight loss that they're after, or just also very low dose when they're seeing that rampant food noise coming back in. I do find it to be a very powerful tool for so many patients.
I think just as GLP-1s may kind of replace some bariatric surgery, they also take one of, weight regain, which has been one of the major and appropriate critiques of bariatric surgery, and they essentially eliminate it. Meds plus surgery, I almost feel like we're looking at like 99% long-term success. I don't have data on that to support that, but I'll tell you in my practice, it's like if I see a post-surgical patient who doesn't lose the weight regain, that would be like shock. I can't even think of someone who didn't respond to GLP-1s after surgery. So that to me is that's really exciting. That's a sweet spot in our practice for sure. I love doing that, and we're seeing great results. So if
and
you
I
are
think also a big
go ahead.
I was going to say, I think also a big piece of this is expectation management, because some people are, go in and say, I want to get surgery, and they feel like that's kind of the one and done, but we have to reframe kind of how we think. It's not that you're going on the medications, meaning that you failed or the surgery failed. It's about, this is like we talked about, the better results, the gold standard of how we can really not only lose that maximum amount of weight, but maintain it long term, and knowing that it's part of the treatment and not necessarily an indicator of failure.
Yeah, absolutely. It's like, like people have hip replacements and then 15 years later, they got to have their hip replacement done again. Did that mean their first hip failed? No, they got 15 years out of it, So, so
Right.
it's more complicated. All right. I think you nailed the second one of this, the second part of this next prediction. So go over that, because I think that one of them you really got exactly right.
Yeah, so our last prediction here is that people are starting to reduce their caffeine and alcohol intake. I see way, way, way more decrease of alcohol
Yeah.
use. Maybe a little bit of caffeine. I will say I've seen a lot of people, still getting their latte or still getting their coffee, but using decaf maybe more often, especially with the rise of people struggling with anxiety. I also see a lot of people trying to decrease their caffeine intake to try to help combat that. But the winner of this prediction for number 10 is definitely the alcohol. Have you seen, I've been seeing so many ads for like alcohol or alternatives, whether it's with THC or even mushrooms or whatever it is that they are kind of replacing the alcohol with. What have you seen much
Yeah,
of
I mean,
that?
I was at the Total Wine, or one of the beverage places, and they had a whole wall of weed drinks. So I mean, I think there's no question when and on our patient intake, how much do you drink? Do you use marijuana? Any other drug use? And I'll tell you what I see. I don't see a ton of alcohol use. I see a ton of marijuana use, tons, and way more marijuana use than alcohol use. When it comes
Mm-hmm.
to weight loss, that is better. There's no question that, and the people think, well, marijuana gives you the munchies. The data doesn't show any correlation between marijuana consumption and obesity. Um, Alcohol consumption is definitely linked to obesity. I mean, you're drinking 2 glasses of wine at night. It's really hard to lose weight, no matter what else you
Yeah.
do. The nice thing too I like about the GLP-1s is the anti-alcohol desire effect, and that's not a bunch of junk. That's real. People just quit drinking once they start taking it. I think that's for the best. We just had now they want to put warning labels on alcohol. Any amount of alcohol causes cancer. There's zero safe amounts of alcohol, and I think that's really important. That's probably a good message for us as a country.
It is very interesting to me. I think it's all societal, right? However many decades ago when everybody was smoking cigarettes and that was what was accepted and that was
Right.
what was normal and a societal norm. But then, of course, the research comes out and now it's, kind of this much
Oh yeah.
wider, kind of like snubbed thing. And it is interesting to know that there is the research there that supports, the cancer in
Yeah.
that alcohol can cause and all of these other health side effects, and like you were saying, the warning labels, but it will take a cultural shift. I think we're starting to see that, but
Right.
I do think it's going to take more time to
Yeah.
see that really robust cultural shift where it kind of has that same messaging around where cigarettes used to.
Yeah. I mean, cigarettes really turned in the 90s, when I think California was the first place to outlaw it in bars and restaurants. And it took 20 years before it became like, oh, look at them, they're smoking. Who smokes anymore? It took 20 years for that to happen. I think 2025, this is the year that alcohol peaked. That's
And soon we're going
my
to be seeing alcohol being barred in bars.
no alcohol in bars. Only weed and mushrooms. Mushrooms are the next big thing. I mean, they're already legal in Colorado, so yeah,
That's so
no
funny.
alcohol in bars. That's funny. All right, well, let's get into our 5 predictions for 2025, or the last 9 months of 2025. Okay, the first one: all of the sleep apnea, fatty liver, cardiovascular, FDA approval, all the data that's coming out that show that these meds are effective treatments of these problems. will not change a thing for insurance coverage. And it's out there. The data is clear, and Medicare is now covering it. But the truth is Medicare is becoming a really small player in health insurance. It's all being subjugated to Medicare Advantage plans, and they can set their own rules and their own guidelines and their own prior auth process, and they can make it next to impossible to get coverage for these meds for fatty liver or sleep apnea or cardiovascular risk reduction. And that's what we're seeing right now. So I think Deidre got our first patient approved for Wegovy for sleep apnea. And she said it took her like 5 letters and 4 appeals and 2 phone calls to do it.
Wow.
It was a tremendous amount of work on her part. Credit, a lot of credit to her for doing that and going that extra mile for the patient. But all of this data is probably not going to change whether insurances cover it, whether your insurance covers it. The only thing that's going to change it is price. The price comes down, everybody covers it. The price stays high, nobody's going to cover it. And that's really what's going to determine it. And that's why I like to see a self-pay market, a Canadian market evolving to get some competition. Unfortunately, the next big drug, retatrutide, is produced by Eli Lilly, who also produces Zepbound. And, we need a third and a fourth. We need Pfizer in there. We need other big drug companies in there producing these meds so that we can see a actual market. And we're not there yet. And so the price is going to remain relatively high this year, and insurance coverage is going to be relatively lacking. All right, Zoe, what's next?
Okay, so my next prediction is that AI meal planning will be the next craze. And obviously, we've already seen a huge increase of this last year. We, like we talked about, are really making this one of the key features and that we're really excited about it with our app. But I'm also seeing this being able to take photos of pantries and refrigerators, or being able to train the AI about your preferences and what you have available. And the key here is, though, yes, AI can make meal plans all day long and not get tired, which is a beautiful thing. But it's still, in terms of implementation, right? Now we have the what, but we still need to bridge that gap with the how, right? And that's what I do with patients, and what I think having that accountability of maybe working with a registered dietitian or working with whomever it is that you might be working with in terms of a weight loss coach or provider, but taking all of this great AI data and tools, but how can I implement this in a realistic and sustainable way for my life? And that's going to be individualized. And that's something that I'm not sure AI is quite, if we're quite using AI in that way yet.
Yeah. I'll take the counterpoint of that, but if you give AI the weights, your weight, you give AI your food log, and you let it write your meal plans, it might figure that stuff out,
Well, hey, listen, Dr. Weiner, I'm not trying to get fired.
No, you'll never get fired. And I think I'm not saying AI is going to replace dietitians. I think, did Weight Watchers replace dietitians? It didn't. In many ways, it kind of created a space for Weight Watchers hired dietitians. Dietitians participated in the development of Weight Watchers. And I think that's going to be more, and that's a big part of how your role has changed in our practice is,
Exactly.
You're still seeing patients and providing that individual guidance, but you're also structuring and helping us build the system because, there's only one of you. You can only see so many patients, but an AI bot can see millions of patients. And so I think the role of the dietitian is going to change a lot from that kind of boots on the ground, talking and counseling to the patients, to more of the building the system and creating a tool that people can use to eat better. And whether that you like it or not, that to me is, I think, where we'll see more dietitians. There's always going to be a role. And in our program too, you can use the bot and you can also meet with you. So you get the best of both worlds. And I think there's some things that you can do that AI will never be able to do. But I think that, we're going to see this in Weight Watchers and Atkins and Keto and Jenny Craig, and all the commercial programs are going to start using more meal planning and automated recipe and grocery lists and all that stuff for their nutrition program. So I think
and I have to say, with training our Sage, our AI bot, it's been really cool from my perspective to be able to help, write that training of how she
right.
responds with aligned with our philosophy, aligned with, not just what's going to be pulled off of the internet, but what we actually work with patients on. So yeah, I completely agree. It'll be very interesting to see.
Yeah. And with AI, you can there can be an angle. Like you can create an AI that does only keto. You can create an AI that does low fat. You can create an AI that counts calories. You can choose a different approach. And so I think that's going to be something you'll start to see is different AI bots. One's on a high protein diet, one's on a high produce diet, and how that kind of gets managed. But yeah, it's going to be, I don't think dietitians are going anywhere, but I think their job's going to change. But honestly, that's true for about half of us when it comes to AI, right? So, all right. The next prediction is a lockstep dose advancement will no longer be the optimal way to take GLP-1 meds. So the standard teaching, and we've even run into insurance companies where we have someone on 2.5 milligrams and the next month we're like, oh, they should stay on 2.5 milligrams. And we submit a prescription and their insurance company's like, no, they have to go to 5 milligrams. And I'm like, where are you coming up with this?
You're like, hello, I'm the doctor.
Yeah. So this idea that first month 2.5, second month 5, third month 7.5, we ramp the dose up just like the clinical trials did. And we follow this very structured, advanced dosing strategy. I think that is going to become less and less accepted. It doesn't make any sense. Patients don't tolerate it. You're going to be on this med for a very long time. I believe the less med you take to achieve the weight loss that you desire, the better. And an analogy I use is, if these meds are messing with your biology, they really are. To say that they're just no big deal that's not accurate. Is there a difference between having 1 drink a night and 6 drinks a night? Massive. Well, maybe 2.5 milligrams of Zepbound and 15 milligrams of Zepbound is going to impact your body, your metabolism differently. And so we have to respect that dose difference. It's such a huge therapeutic window that we're using that just going up to the highest possible dose, I don't think is the right strategy. I think over time we'll start to see this no longer being accepted and more of a flexible dosing strategy, and involving the patients more and more in determining the right dose is going to become how these medications are used. All right, we're running low on time. This has been a long episode. I'm going to kind of crank out my last prediction. This is a bold one. I'm really going for it with this one. Retatrutide is going to come out. It should be FDA approved later this year, and it is showing even better weight loss than Zepbound. It's produced by Eli Lilly, and it is going to be pulled off the market at some point in the next few years. It is a triple agonist, meaning it works on GLP-1, it works on GIP, and it works on glucagon. And it's the glucagon component. Glucagon is a stimulant. It's similar to epinephrine. And my concern is that we're going to see cardiovascular events. Their initial data shows a reduction in cardiovascular events, but I think if you're trying it on young, healthy people, we're not going to see it. But I think you start using this medication on older people with pre-existing cardiovascular disease, and I think we could see this medication causing cardiovascular events. And so I know when this med comes out, I'm going to be very, very careful in using it, particularly in older people. It's a great med. It's showing a lot of promise. It's not FDA approved, but I have a lot of concerns about cardiovascular safety, particularly in older patients. And so we'll have to see where that turns out. I'm saying that speculatively. Please don't take that as Dr. Weiner says this med is bad. It's not even out. There's not even a lot of data on it. But I'm going to look at that very, very carefully. And I don't know if it'll be pulled off the market, but it may come with a very, a not to be used over the age of 55, not to be used in people with pre-existing cardiac conditions. I think we're going to see some concern about that glucagon agonist and the cardiovascular risks associated with it. All right, Zoe, you get the last prediction. What do you got for us?
Well, we know how popular GLP-1s are and how many other and how many companies are trying to get in on the action. So I
Yeah.
predict that there will be a ton of GLP-1 specific support products, but they're going to be a waste of money and not very useful. We've already seen this. I think we've reviewed a while back a protein specific for it. We've been seeing those freezer meals, like, the lean cuisine specific to GLP-1s. And, I've been seeing, who was it? One of the Kardashians had her like
Yeah.
GLP-1 gummy or whatever. So I think we need to be very, very weary of all of these GLP-1 specific products and knowing that they are likely just a way to make more money and to prey on people who are on the medications and obviously want to get the best results, but also to know that you're never going to out supplement your nutrition choices. So just because you're taking a GLP-1, what's the word I'm looking for? Promoting, result promoting supplement along with your GLP-1. If you're not changing the way you're eating, you're still not going to get the best results. So I would say we're going to see a lot of products, and I'm sure we'll pop them on the podcast as we see them, as the year goes on. But definitely be careful if I know that in our sessions in the nutrition program, I review products all the time. People are like, oh, what about this one? Right. So we look at that a lot, but reading labels, looking at ingredients, and knowing that most of the time your best bet is to eat whole, real, unprocessed foods that's going to help you get the most well-balanced nutrition, getting in the nutrition that you need to not only get the best results for your weight loss, but also to feel your best and to minimize those symptoms.
Yeah. I mean, I think GLP-1s, they work to lower your set point. They kind of cause your body to lose weight in a natural way. And so they're not going to change the rules about what's right nutritionally and what's right from a supplement perspective. There is one thing, amylin, which we can talk about on another episode. That I think is worth diving into a little bit more. And there's some reasons why I think that, but we'll cover that another time. But other than amylin, I'm right there with you. I think diet products follow the fads. Atkins is out there. Everybody's got a high protein, low carb product. What's the new diet fad? GLP-1s. That's the new diet fad. So we should expect to see a lot of products following that. But the data behind, they don't need the data to put it out there, to put the marketing claims out there. And so just be wary that that's going to happen. Just because you're taking a GLP-1 doesn't mean you should be looking for these other products to support you. You should be supporting yourself with exactly what Zoe said: unprocessed foods, eaten appropriately. All right, great episode. A lot of content. We reviewed a lot, and I look forward to going over this in 2026 and seeing how we did.
Yes, absolutely. And, if you found this episode valuable or helpful in some way, we encourage you to, please ask, share this with somebody
Yeah.
that you think is going to get some value out of it. We know how much of a trend and how much of a craze these medications and this whole conversation is. So chances are that if you're listening to this, you probably know somebody who also could benefit from it. And our main mission is to give the most scientifically sound advice and to give it to you with none of the BS. So that is unlike a lot of social media content out there. So we're trying to help us make our mission possible by sharing the good information.
Absolutely. All right, we'll see you guys next time.